We are live now, doctor. You can start the
Okay.
session.
Yes, Chito.
So good evening and welcome all to this felicitation ceremony of VRSI monthly image competition for the months of July, August, September, October 2023. May I request Dr. Naresh sir to please welcome all the panel dignitaries and a brief introduction about the competition. Dr. Naresh sir, please.
Yeah, thanks, Chito. Actually, sorry for the delay in this award ceremony because we had VRSA. That's the reason why we couldn't do it in the last 2 months. But anyhow, the competition has been happening regularly. The new thing which we have done in this is unlike the previous ceremonies where will be only the task force will be hosting this. We have formed a panel so that these interesting cases can be discussed, and we have got an esteemed panelist, Dr. Mahesh Gopalakrishnan, Dr. Derais, and Dr. Mudit Tyagi. And as I keep telling, like many of these images have been published as the cover pages. And before we go into the program per se, should be moderated by Dr. Chitranjan. I want to tell all the participants only one thing. See, we have got only 1 minute time for explaining your image. So please avoid all this, the Thanksgiving, thanks to X, Y, Z and all. Straight away, we'll get into the business because we know that we are a very thankful society in the world. Okay, over to you, Chitranjan.
Thank you, sir. Just before starting the award ceremony, I just mentioned that we have sent the physical certificate to all the winners. They have received them, and regarding the award money, we're just yet to receive some some awardees' bank details. So we'll be dispatching them in 1 week more. So coming to the winners, the July month 2023. The third prize goes to Dr. Vivek Chaitanya. Dr. Vivek is consultant veterinary services, Sankarai Hospital, Coimbatore. So this is the award-winning image, lipemia retinalis, very nicely documented. And this is the text Dr. Vivek has mentioned about this award-winning image. May I request Dr. Vivek to please describe this image, lipemia retinalis. Dr. Vivek, please.
Thank you, sir. Good evening to everyone. So this case is a 42-year-old female who is a known case of type 2 diabetes mellitus and dyslipidemia. She presented to us with a best corrected visual acuity of 6 by 12 or 6 by 9 parts. On examination, her anterior segment was almost unremarkable, for except some mild PSCC was there. Posterior segment evaluation showed this picture of a creamy white discoloration of the retinal vessels with a little bit of a salmon color appearance of the fundus, which was pointing towards the diagnosis of a lipemia retinalis. On further probing the patient for blood investigations, we found that the patient's random blood sugar was 545 milligram per deciliter. Her renal profile comprising of blood urea and serum creatinine was normal. Her lipid profile was total cholesterol was 409 milligram per deciliter, and to alarmingly, her triglycerides were around 1,374 milligram per deciliter. So we counseled the patient to get an urgent systemic evaluation done and referred her to a nearby endocrinologist for managing these altered blood profile. And just we are awaiting the results for the same.
Thank you, Dr. Vivek. May I request Dr. Mahesh Gopalakrishnan sir to please give his inputs on this particular disease entity and the imaging, the images per se. Dr. Mahesh sir, please.
Thank you, Dr. Chitranjan. Nice photo. Actually, it's quite rare. I have come across one or two only. This is just we have to send the patient to an internist as soon as possible, because in most of these cases triglycerides are very high. That is what we have seen. Here the blood sugars are also uncontrolled, right? So this has to be sent to a physician, and I don't know about it's fibrate that is fenofibrate that is given for triglycerides. I am not sure. Just
yes, so that's the primary modality of treatment.
Yeah. So this is just a warning sign that we can pick up many times and send to a physician and save the patient.
Thank you, Dr. Mahesh.
Just a word of thing actually. One thing is with the lowering of the triglyceride level even to less than 1,000 reverses it, number one. And number two, if you take the test tube, actually test tube will be, the blood serum will be in milky white color rather
Milky
than
white.
blood actually. So that also when we are drawing the blood gives a clue about the lipid analysis. Usually it is associated with type 1 diabetes mellitus, most common. Right,
Thank
Chito, over to you.
Yes, sir. Thank you, Naresh, sir. Actually, we have been we are told in our fellowship period that if the triglyceride comes in thousands, not in hundreds, then obviously you suspect lipemia retinalis. And as Dr. Vivek has told about the salmon color thing, there are three grades or stages we can tell. Probably we can tell grade 1, 2, 3. Grade 1 is something where we get the periphery vessels. They are kind of creamy or milky kind of thing. And grade 2 where the posterior pole vessels are also creamy and milky. Grade 3 where you get, in addition to the vessels, the retina also is salmon colored. So not all cases we get grade 3. Some are also during ROP screening, at least I have seen one baby where it was a grade 1 lipemia retinalis. And as Dr. Naresh rightly told, there is a very interesting image in NEJM. All of us we know NEJM clinical images. There is a nice image where they have shown the supernatant fluid that is turbid kind of thing. So and regarding the management also, Dr. Mahesh sir told nicely. So nice photo again. Congratulations, Dr. Vivek. So,
Thank you, sir.
he wins 2,000 rupees our money and a certificate for this. Congratulations again, Dr. Vivek.
Thank you, sir.
Coming to the second winner, Dr. Kanwaljit Navjot Madan. Dr. Kanwaljit Harjot Madan is
Yes,
fellow
I'm-
with No, I'm
I'm here,
just I know you are there. So she is veterinary surgeon in Thin Eye Hospital, Jalandhar. And this is a very nice, interesting image of a second baby syndrome, not a very common finding. And this is the description she has provided regarding the image. And may I request Dr. Kanwaljit Harjot Madan to please tell something about the image.
This is the fundus picture of a child, left eye, and the child was 7 years. He presented in the OPD with a sudden decrease in the vision in both the eyes. The vision in the right eye was 6/12, and in the left eye was counting finger close to face. And on examination, the anterior segment was quiet, and the posterior segment in the left eye showed these multiple retinal hemorrhages. They were present all over the retina, and they were at all the levels. There was pre-retinal hemorrhage, intraretinal, and a few subretinal hemorrhages also there. And they were extending till the periphery. And in the right eye also showed a few hemorrhages, but they were less in number than the left eye. And on history taking, there was a history of physical abuse. And the child was kept under observation for this ocular findings. And but hematological examination was also done to rule out any blood dyscrasias. And the patient was referred to pediatrician and neurologist for further opinion. And there was history of physical abuse. And further follow-up, the patient vision improved to 6/6. So on the history taking and the clinical exam, we made a diagnosis of shaken baby syndrome.
So may I request Dr. Unni sir to please tell about this image? Sorry, second baby syndrome. Like it's a rare entity we know, but like in today's world, how commonly we see and any management things regarding this? Dr. Unni sir.
Yeah, so I mean, it's a very wonderful, nice image. One of the key points here is having hemorrhages at different layers that the doctor has mentioned very well. Other associations could be retinal ischemia happening at the posterior pole. Sometimes when the hemorrhages are not that obvious, you have occasionally a macular ischemia type picture can also be seen. So basically the diagnosis is in the fact that the hemorrhages are at different layers, and also this is also very similar. That is why the hematological evaluation, any hematological condition that produces a hyperviscosity syndrome in a very short period of time can produce this multiple layer hemorrhages also in a similar picture to a shaken baby. And moreover, then the neurological examination, thorough social care has to be taken for this particular condition, evaluation for other concomitant injuries in other parts of the body, broken bones, fractures, rib fractures, and all these have to be looked at also. Yeah.
Okay. Thank you, sir. Thank you for the nice input. Naresh sir, anything additional for this?
Nothing, Chittaranjan. What I think is the society has to correct itself to not to have these sort of syndromes in future.
Yes, sir. So, Murli sir, we are having Dr. Murlidhar sir with us. Dr. Murlidhar sir, about this.
I just joined, so I'm not really conversant with the case and this one, but the picture is very, very dramatic and really, I'm sure this is really an image that is very unique. And as I think I heard Uni mentioning that our role not just is limited to the eye, but we must also look at the general examination of the patient, because some head injury and other fractures also may be there. So the role of ophthalmologist is to pick up this and also alert the pediatrician and the other family. Although I must say that in my own practice, I have not really come across this having a patient with a shaken baby syndrome. I can't say that I have had any personal experience. We have read about it. We know about it. Others who have had some personal experience probably can share their experience, who have seen cases may share their experience.
Anybody in the panel who has seen these kind of cases? Okay, so as we can see over here, this particular image, particularly this condition is rare, and this one also raises our antenna towards the systemic associations. Additional thing I'll tell that the medical legal issues associated with this, there will be so many kind of say dispute or other thing where we should be like we may not be directly involved, but we should be careful about. So congratulations again. We win the second prize and 2,000 rupees for this prize. Congratulations again. Then we come to the first thing about July month, but Mary got done. That Mary is VR consultant in Arvind Eye Hospital, Madurai, and this is the award-winning image. The title she has given, prodigious yet innocuous, the giant vessel, and this is the description she has given, congenital retinal microvessel. May I request Dr. Mary to please describe this image?
Good evening, sir. Am I audible?
Yes, Mary. Please go ahead.
Good evening, everyone. So this is an accidental finding in a young male, and this is actually a congenital retinal macrovessel that is an aberrant retinal vessel that typically a vein that emanates from the optic disc and crosses the horizontal raphe. And visual loss may be very unusual because in this case also the patient has 6/6 vision. And if there's a vision loss, then the usual causes can be macular hemorrhage, macroedema, macular ischemia, serous macular detachment, and branch retinal vein occlusion. Thank you.
Okay, thank you, Mary. We have Dr. Kim sir with us. May I request Kim sir to please tell about this image, this particular condition?
Thank you, Chittaranjan. I haven't seen this case. I'm surprised and surprised, but I'm happy to see this image. But I'm surprised the patient has got 6/6 vision because the blood vessel seems to be passing right through the fovea. So I think there should have been a structural alterations. I wonder what the OCT was like.
Mm-hmm. Mary, did you do anything OCTA or anything?
No, sir.
Mary, you would expect some OCT changes in this because it is passing through the fovea, right?
Yes, sir.
So you didn't take a OCT in this case, is it?
But sir, maybe not because the patient came for the other eye. The other eye had ERM, sir.
Manoj, can you mute yourself?
Hey, sir, can you help us in this? Someone is okay.
Chittaranjan, I have nothing more to add in this, Chittaranjan.
Okay, sir. Thank you, sir. Again, Dr. Mahesh, sir, anything you want to add, sir? Congenital retinal macrovessel.
I have not come across actually. This theoretical part I have read, but I have not come across the macrovessel. But as per the Archer classification, this is part of the this thing, AV malformation.
Yes, sir. This is stage 1, sir.
Yes.
Okay, okay.
He has actually
Oh,
mentioned
good.
that probably. Yes, he has mentioned in the text also, the Archer's classification.
Okay. That racemose angioma and all comes in the last group, huh?
Yes, sir.
Okay, okay.
Yes, sir.
Okay. Okay. No need of any treatment, right? Unless it
Correct, sir. No need of any treatment. If like this is incidental finding, only 6/6 visions he has told. Probably some minimal metamorphosis or something might be there, but the patient did not complain anything. So we'll just do close follow-up.
Yeah. Thank you.
Okay. So congratulations again, Mary, for the first 5 winners for the month of July. She wins 5,000 rupees.
Thank you, sir.
Mary wins 5,000 rupees for this. So now we move to the month of August. The third prize winner is Dr. Reena Bansal, madam. Reema, madam, are you there? Madam, actually, so she needs no introduction. Actually, she is professor in Advanced Eye Center, PGI, Chandigarh. So very interesting image we can see over here. Okay, in her absence, let me explain about this image. So this is a case of, this looks like a central retinal vein occlusion. The title she has given is metastatic bilateral optic nerve infiltration in a 46-year-old female with CA breast masquerading as CRVO. So not all the fundus that looks like splash tomato appearance are bound to be having CRVO. So here actually the patient was harboring something CA breast. In fact, she was treated for that also by the oncologist, and the patient presented like this. And unfortunately, the patient was lost to follow what she has mentioned in the text. So regarding this masquerading thing, how commonly we come across in cases of CA breast? We have Dr. Darius Shroff sir with us. May I request Darius to please tell about this clinical condition.
Yeah, I think it also is related to the hematological kind of picture. So I think that is one of the reasons that is there. I'm not able to hear you clearly. I'm just going to log off and log on again. So just give me a minute. You can carry on the discussion. Sorry.
Okay, okay.
Actually, Chittaranjan, if you know that such a patient had a malignancy, then we will know, we will suspect. Otherwise, when this patient comes like this, initially, this infiltration we may miss. We think that bilateral RVO. So that is the main thing. So this sort of infiltrate probably is the catching.
Yeah.
Correct, sir.
No.
I think the clue here is the disc itself looks different than what you would see in a bilateral regular CRVO, where the disc would be swollen and hyperemic. Here, the disc is having a totally different appearance. I think that should alert us to the fact that this is not a normal CRVO. Patient must be having some other systemic factor. And whenever there is a bilateral presentation, then often systemic factors has to be suspected.
Also, the distribution of the hemorrhages is very different compared to CRVO. The disc is one glaring thing because you don't see this kind of a disc in bilateral CRVO. Plus, even the distribution of the hemorrhages, the blot hemorrhages, standing alone, I think those are some indications that it is very different.
So points well noted. First of all, we should take a very meticulous history. There is no substitute to that. And second thing is, as Murli sir and Kim sir has told, this is not a typical CRVO look kind of thing, starting from the optic nerve head and the pattern of hemorrhages. So these are the things which should make us suspicious about the systemic things. And congratulations to Rima madam again. 2,000 rupees. Then the second winner again, Dr. Mary Kodvarni. So Dr. Mary wins the award for this particular image, which she has captioned as "Lunar Halo in the Midnight Fundus, a Celestial Glow." So Dr. Mary has become kind of, she's blending poetic expression with VR science and images. This is the explanation she has given. So we all know about the classical dark choroid sign, which we have read in our textbooks. And this is the image. Mary, you want to explain this image, please? Go ahead.
So this is a FFA of a Stargardt disease. The peripapillary dark choroid ring sign is a typical of the late stage disease that we can see here. And the retinal blood vessels are highlighted against a hyperfluorescent choroid, which is the early choroidal fluorescence blocked by the lipofluorescence in the RP. And also the flecks that are present are hyperfluorescent due to blocked transmission, and it can be hyperfluorescent in the presence of atrophy. Nothing more to add, sir. Thank you.
Okay. So may I request Naresh sir to add something to this, please? The dark choroid sign in Stargardt disease. Naresh sir. So it's there.
Chittaranjan, this is due to the lipofuscin in the layers, now blocking the choroidal fluorescence.
Yes, sir. The choroidal
Yeah.
fluorescence is blocked. Yes, sir.
Here it is little late phase. That is why that staining of atrophic area is also there.
Correct.
This
correct.
is yeah. So otherwise that it will be totally black initially.
Yes.
What
Correct.
stage was this taken at? What timing was this image taken?
Mary, please.
Okay.
Mary, are you there?
I don't remember the exact timing, sir, but it's taken the late phase only, sir.
Yeah, I think that's what Dr. Mahesh was. But it's a
Yes, sir.
beautiful image. I think congratulations. It's a really
Thank you.
beautiful.
Thank you, sir.
And just to add, sir, Mary has got this image accepted in iJournal. Am I correct, Mary? As a cover page image.
Both the images, sir.
Both the award-winning images of Mary has been accepted in iJournal. But the thing is that the iJournal comes up with the publication many months or sometimes many years after the acceptance. So that is a thing. But anyway, congratulations, Mary.
Thank you so much, sir.
Yes. So anyone wants to add to this image? Dr. Manoj Khatri sir is there with us. Dr. Manoj, you want to add anything to the dark choroid sign?
No, nothing much to add actually. It's just a lipofuscin deposit, as all we know. And beautifully captured image, and many congratulations for the publication in iJournal.
Thank you so much, sir.
Correct. So again, congratulations, Mary. She wins 3,000 rupees for this image. Then you come to the second winner. Again, this winner is Santosh, who is Vikrata surgeon. We are surgeon in Girdhara Institute, Cochin. And this is the award-winning image, the incomplete web. She has mentioned it, incomplete web. This is the text she has given for the image. This is a case of IRWAN, idiopathic retinal vasculitis, aneurysm, and neuroretinitis. And may I request Dr. G. Mary Santosh, if she is there, to please describe the image. She had FAISO exam today, she was mentioning. I believe she could join. Dr. G, are you there? So, okay. So if she is traveling or something in her absence, maybe I'll request Dr. Mahesh sir is there. He is the right person. Probably would
Actually,
have.
yeah, I have not seen. This was our fellow only. I have not seen this case, but nice picture. In fact, this neuroretinitis is a misnomer in IRWAN. It is not actually inflammation. It's basically a vascular thing, right? Neuroretinitis. It has multiple neurosomes and non-perfusions. Usually asymmetrical. Here it is symmetrical in both eyes. And all other causes of vascular, other causes have been ruled out by systemic investigations. That is why I think she came to a diagnosis of IRWAN.
Correct. Dr. Darius sir, you want to add anything to this?
Yeah, I would like to ask how this case was managed, because I think with so much peripheral CNP, probably they would have done a peripheral laser. And I think the white.
Yeah, I think peripheral PRP to the area of non-perfusion was given. That is what I think.
And so what imaging system was used for this? Because the image is really beautiful.
Heidelberg only. Heidelberg, that Whitefield,
lens.
that is not true Whitefield. Yeah, lens.
Okay.
The
I think
eye seems to be the one that is affected more, because right eye, I think the ischemia is not much. And even in the left eye also, you can see multiple areas of neovessels. Probably on the disc, there are some leaking vessels and temporal part. So
yes,
probably like it may not be bilaterally symmetrical. I think it is asymmetric. The left eye being the eye with the more involvement than the right. Like what we see in IRWAN always. Yeah. But it's a nice picture and a nice caption too, like a spider's web that it shows. Yes.
One classical sign of IRWAN is like the presence of arterial knots which are present in these eyes. If you follow the arteries, there are arterial dilatations at various intervals. So this is one classical feature of IRWAN. If they are present, should think of IRWAN.
Sir, she has actually mentioned in the description the capillary knots and vascular dilatations and the aneurysms. That's what
Yes.
she mentioned. Yes, sir.
And the beauty is of wide-field angiography. It shows these peripheral CNP areas so well.
Yes,
otherwise, although I think in a normal angiography camera, it would have been picked. But this good a picture, it's not possible with a normal angiography, I guess.
Yes, sir. The peripheral avascular areas would have been missed.
Yes.
This kind of a picture is only possible in a SLO-based.
Yes.
Not
Yes, sir.
possible in a flash-based
Yes.
camera. It's not possible.
Yes.
So congratulations to Dr. G. Mary Santosh. She wins 2,000 rupees. Coming to the first Dr. Sai Prasanthi. Dr. Prasanthi is VR Fellow in Naran Netralaya, and this is the award-winning image. She has captioned it as PKBoo, very rightly captioned. And this is the description she has given, Dr. Prasanthi. Dr. Prasanthi, can you please describe this image?
Good evening, everyone. So this is an ultra-wide field Optos image showing 360-degree choroidal detachment in a middle-aged lady who underwent glaucoma filtration surgery. Following poor IOP control, bleb massage and suture release was done in this patient, which ultimately led to a hypotony-induced choroidal detachment. At the point of capture of this image, the vision in the right eye was 612 and the intraocular pressure was 2 mmHg on applanation tonometry. So this image, basically it highlights the panoramic view that we can see with Optos, which is a non-contact CSLO-based imaging system. even when the pupil is not dilating properly, or even in an undilated pupil. But this is a pseudo-color imaging system which may have a bearing on the identification of lesions with different colors. So in this particular patient, CD drainage was done, following which there was a recurrence with massive kissing choroidals and retinoretinal adhesions. The fellow eye also had glaucomatous disc damage secondary to PSEG with IOP, which is currently being maintained by AGM.
Correct. So nice description and nice image. May I ask Darius sir to please tell about the imaging of the choroidal detachment, because she had optos, so that's why she could get nice image.
Yes.
Like otherwise, it is always challenging, isn't it, sir?
Yeah,
Like,
that is true. This is a beautiful optos picture, and through a small pupil also, because glaucoma patients often have small pupils, they are on pilocarpine, etc. So this is a major advantage. But my question is different. I said, normally if the hypotony is the cause of the choroidal detachment, we don't really go after draining this. We would prefer to just control the pressure and these resolve with atropine and steroids. So what is the thought process behind trying to drain this kind of a case?
Dr. Prasanthi?
Sir, actually, this patient was a diabetic, and also she was on dialysis as well. We actually initially started her on topical steroids, cycloplegics, and also on oral steroids. But the choroidals were still progressing, and the vision significantly had come down. Initially, it was 6/8 in the right eye, and it came down to 6/12, and again it came down to counting fingers. That is when they went ahead and did a drainage.
Okay,
I
because
think
I
other
think
point is, Dryas, is
Yes.
once there is a retinal adhesions forming, how
Yeah.
long does it take for retinal adhesions to form? So I guess it's better to intervene early.
Yeah, but
rather
I
than
think
late.
if we don't have the primary cause of the hypotony in place, this is going to happen, because I think they drained it and again there was a recurrence. So it did not
Yes.
help. The drainage did not help. So I think going after root cause is important. And then if you drain, then you have to go all out, put oil and
Yes,
put a lot of
absolutely.
sutures also. I
My
think there's
question is,
we
how
cannot do it
long?
halfway.
How long
We
to
can't.
all the seniors here? How long do you wait once you see this retinal adhesions? I mean, retina kissing choroidals with the retina opposing each the surfaces. How long can you wait?
So I think this
agree.
is post valve surgery, I think. So usually in post valve surgery, most commonly we come across hemorrhagic CDs. I don't know whether they have the ultrasound image of this, and when they drain, I don't know whether they found blood in that or only the serous fluid, because very commonly we come across hemorrhagic CDs, and in such cases we wait up to 10 days for the blood to lyse and then we drain in this case. So was there any blood coming through the drainage port when we are draining, and how far from the limbus it was drained, and what was the infusion used for this drainage procedure, doctor?
Sir, actually, in this particular patient, B scan was done before we went ahead and did the drainage. It was serous CDs only, sir. And the 6 mm cannula was used for the drainage of the.
No, 6 mm in the sense. Now, how far from the limbus you made the port to drain the CDs? It was a single port or two on both the sides it was drained?
Single port only, sir.
Okay. So many times we go for a vitrectomy also, and you can retain the PFCL for a day or two, so that it completely presses out all the fluid, and then you can replace it in case if you want silicone oil.
So we did the same case. We put a NTA chamber, maintainer, did a PI, and let the fluid go through the zonules, because we could not find a place to place the cannula. So that was, and another thing is that won't hemorrhagic choroidals will have increased pressure rather than pressure of 2 mmHg?
Yeah.
I actually agree with the Darius. In fact, the cause, if it is a leaking blood, that has to be corrected, or if it's a leaking tube, that has to be ligated. So then, if that still it is not going, probably drainage can be considered. That is what, yeah.
But this is a serous choroidal detachment, no, not a hemorrhagic one.
Not hemorrhagic, no need of.
Yeah,
but usually,
due
sir,
to
theoretically.
hypotony. So in a serous choroidal detachment, I don't think you will end up injecting silicone oil and all that. That is in a hemorrhagic choroidal detachment, expulsive hemorrhage, yes. But,
Sir, I think what Dryas wanted to say was if it's recurring, then probably once you have gone in and
Yeah, I think the best
maybe
is to kind of get the source. If it's leaking,
yes,
leaking bleb, you have to kind of get rid of the hypotony.
yes.
And till that time, I think other than topical atropine, even ointment atropine also works very well. So I think some of these old medication we had are really good tools for this sort of cases.
And one more thing, actually, theoretically, serous choroidal detachment should not extend to the posterior pole because of the vortex vein which anchors. So only hemorrhagic choroidals extend to the posterior pole. That is one theoretical thing.
No, but there is one other concept there that a rapidly developing serous choroidal can develop into a hemorrhagic because of avulsion of the vein. That is what where you can have a hemorrhagic choroidal in the presence of hypotony when the serous choroidal has progressed so rapidly. And that answers the question as to when you will interfere. If you have a choroidal that is progressing slowly in time, your measures to increase the IOP will work. If you have a choroidal that is rapidly progressing into a kissing choroidals, you have to take care of the primary problem while preventing retinal adhesions also. So the time frame of progression of choroidals may be a very important factor to take a decision.
Correct. So one more question to Dr. Prasanthi. After how many days you intervened, did the surgery drainage?
Sir, actually, initially, first time the CDs were noted in the month of June, and then the surgery was done in September.
Okay. Great. Okay, so nice. So we had a very nice discussion about the management of choroidal detachment in this case. Regarding the the imaging technique, I just want to add one more thing over here, that all of us know that capturing CD is difficult, but particularly in Optos, it is a little easier. Why? Because Optos and Clarus, what we have to compare for us, the wide angle or ultra wide angle imaging system, the difference is that in Optos, we can see the different depths over here. Like we can see the CD, the amount of CD over here, and we can see the posterior pole disc and vessels retina clearly. That means both of them are in a different level or different depth. Still, we can, with some clarity, we can capture this, which is little difficult in the true color Clarus. So rightly, she has captured the image in Optos. No financial interest, just the finding. So again, congratulations, Dr. Giving 5,000 rupees for the first prize for this image. Then we come to the September month winners. The third winner is Dr. Sisir Varghese. Dr. Sisir is currently in Amita Eye Care Center, Kerala, Tiruvalla, and he is alumnus of Arvind Eye Care System, Coimbatore. So I'll just show yes. So this is a video. This month we had the videos for the competition. I'll just play the video over here. The title is Time to Chill. Dr. Sisir, you can start describing the video. Dr. Sisir.
So this was a surgery of a 65-year-old one-eyed lady with advanced proliferative diabetic retinopathy. So did extensive membranes were there extending till the equator with adherent vitreous up till the aura. So during my fellowship, I've always heard about port site neovascularization, port site neovascularization. You should always check for that, especially during, when you do a vitreous lavage. But this I actually found neovascularization at the aura in a case where the vitreous was extremely adherent up till the aura. And so towards the end of surgery, I could clear maximum up whatever I could till the equator. And then whatever at the periphery, like this NVE was there, I just cryoed it. So it was very intriguing for me because I saw it first time when I was operating. So that's why I decided to just frame this and just send it up as a video. Yeah.
So very short video, but very nicely captured. Thank you, Dr. Sisir. And may I request Dr. Kim sir to please tell his comments on this. Cryo for port-sized neovascularization. Kiran
Yeah,
sir?
that's a very good option. In fact, the most easiest option, which we used to use a lot in earlier cases, when the visualization was very difficult, but it is very effective. I think she has captured it so beautifully.
Yes, sir. Yes.
I think for all those, neovascularization, especially in the secondary vitreous hemorrhage that's happening, this is very important to see this and identify this and make sure you take care of this. So, yeah, good video.
Thank you.
Chitranja, during the early days of 23 gauge or 25 gauge, whenever there is a recurrent hemorrhage, this was found to be the culprit, and we have been doing a cryo for all these sports initially.
Okay, sir. Correct. But the beauty...
maybe UBM is useful in these cases whenever there is a reproliferation at the side of the port.
Yes,
UBM is very useful.
Yes, sir. But Sisir has very nicely captured this particular, like the new vessel becoming blanching thing that he has captured very nicely. Very short video, but nicely captured.
Can you just play the video again? Just
Yeah.
Yes, sir.
How is it illuminated? I would like to ask Dr. Shishir.
Yes, Sisir, please tell. I'll just play it again.
Because is there chandelier kept there? At the
Yes, sir, it
source?
was a bimanual surgery was done. So chandelier plus the light pipe, both I had used.
Okay, that's why you got a very good illumination of it.
Correct.
okay.
It is adjacent to the chandelier, I think.
Sorry?
It is adjacent to the chandelier.
Right next to the chandelier, sir. The chandelier is right in the...
Yes, it's adjacent to the chandelier.
Correct. So, congratulations, Sisir. 2,000 rupees for this very beautiful video.
Second winner, Dr. Savin Gupta.
Dr. Savin is retina surgeon in Poli Eye Hospital, Ludhiana, and again alumnus of Arvind Eye Care System. So may I request Dr. Savin to please describe the video. I'll just play for him.
This is a case of chronic macular edema with focal tractional detachments. Vitrectomy with ILM peeling was done. This video describes the importance of identifying second membranes and also the technique to peel ILM in edematous retina without causing any foveal tractions. After core vitrectomy, membranes were segmented and removed. Nasal proliferations were removed by pulling it tangent to retina from disc using max grip. If you see, macula is free from any membranes. Now have a look on this OCT, there is present vitreocysis, in other words a second membrane, which if not removed, will lead to persistent traction over macula, thereby non-resolution of macular edema. Identification of second membrane is also important, as it is the correct plane of dissection, which leads to an easy removal of membranes without any retinal injury. OCT of macula shows acidic retina with large, subfoveal cyst. The roof of the cyst is very thin, any sort of traction will cause its deroofing, leading to lamellar hole. So if we pull the ILM across the macula, it will cause traction and will lead to dragging. Instead we should peel ILM all around fovea first and then gently pull the ILM over fovea in the end. This technique is the safest way of peeling. Note in this video, only the gentle pull in the end, cause the release of ILM flap. As described in animation, ILM flaps were raised from 4 sides and peeled till fovea, and just a gentle pull is all that required to free the ILM flap, thereby causing negligible traction over fovea. Surgery was then concluded with fluid air exchange. Thank you for watching. Any comments and opinions are most welcomed.
This is the short slide that Sabine has shared. That Sabine, please.
Good evening. Thank you, sir. Good evening, everyone. This video is basically to describe the surgical management of diabetic macular edema. This patient was being injected multiple times outside with Ozurdex injection as well as the anti-VEGF injections. It was not improving. Basically, there was a layer of there was a that second membrane that was lying over it that was preventing the macular edema to subside. So I thought of going for a surgical thing, and this video basically describes the correct method of lifting the second membrane, the identification of the second membrane, the importance of the second membrane in the membrane peeling cases, and lastly, the ILM peeling technique to prevent formation of lamellar hole. Thank you.
So nicely put and great learning points for the fellows or beginner surgeons. Dr. Sangeet sir, any comments on this diabetic vitrectomy tutorial? Sangeet sir?
Yeah. Nice video, Sabine.
Thank you, sir.
I think just wanted to know when is your this endpoint that injections are not needed now? Did you use the OCT as a guide, or did you use the multiple injections which were not responding? The patient was not responding to it.
Sir, actually, patient was taking treatment from outside itself, and he was being injected, and the OCTs he was having, there was no significant change, and I could see that the thick layer over the retina. So at that point, whenever I find that thick membrane, so I always go for surgical treatment rather than injecting, because it really is not helping the patient.
Yeah, I think you are right. These kind of patients who have these epiretinal membranes which are causing macular edema, I think it's an indication for a primary vitrectomy rather than keep on injecting the patient with anti-VEGF.
So correctly, as Sangeet sir has told, these are the kind of OCT-based decisions that make us take the decision in the favor of surgical management rather than medical, and also the patient has taken multiple injections prior. So nicely told and very nice video. Congratulations again.
Thank you.
Again, there's 3,000 rupees for this nice video and lot of learning points. The second winner again is Dr. Atul Dhawan, Medical Director, ASG Hospital, Kanpur. So this was a tie. 2 videos were there. And this is the cap technique for which Dr. Atul has got the award. So I'll just play the video. Cap technique.
Colored viscoelastic is prepared by mixing a drop of brilliant blue with low molecular weight viscoelastic in 1 ml syringe.
This is in vitro movement of the transparent viscoelastic. This is in vitro movement of the colored viscoelastic colored by brilliant blue stain.
180-degree ILM flap without radial cuts assisted by CVT. This patient was a known case of primary open-angle glaucoma with best corrected visual acuity of 6/60 and cupping of 0.8. In this case, same technique was followed. Peeling of ILM was started from one side and slowly extended to the other side. Flap was just placed over the hole. After this, temporary tamponading by colored visco was done, followed by fluid air exchange. On 1 month post-op, U-shaped closure was seen with visual acuity of 6/60.
Nice video and nice innovative technique. Please describe, Dr. Atul sir.
Thank you, Chitranjan. It's a simple way to do the ILM flap technique, and this was done when I was learning the way how to keep the flap over the hole till the last part of the surgery. And this video I have made in 2000 last of 2017. So at that time I was really struggling to keep the flap over the hole till the last part of the fluid air exchange. Flap was moving here and there till the last part of the surgery. So at that time, what I did, I put the viscoelastic, but I was not able to see the viscoelastic at the end of the surgery. I want to take it out. So I thought what we can do. So I have just colored it with the brilliant blue and put it over the temporal side, then tilt the eye towards the disc, do the fluid air exchange, and as usual, I exchange the air with the SF6. But nowadays, after the 6-7 years, I can do the same thing where the things we have to keep, remember that we have to make a large flap. We have to keep a single flap over the hole. Flap is not buried. Just keep the flap over the hole. And at the last part of the fluid air exchange, be there for the last 2-3 minutes to take out every single drop of the fluid. Because when you will shift the patient from the operation room to the ward, if some fluid is there, a couple of drop also, this can lead to the displacement of the flap in the early part of the post-op period. So 3 minute, all the fluid take out from the eye, and then SF6 or air, whatsoever you are using, that is enough for the hole closer. Thank you.
Thank you, sir. Nicely explained, and the importance of completely drying in a case of macular hole. May I request you to Naresh sir for his comments, please?
No, I have not done this, Chitranjan, in the sense using the visco. But drying the macula or the fovea itself gives a good results in most of these cases. And these are required for usually the large macular holes. And everybody has their own technique. Somebody does amniotic graft, somebody does inverse flap, somebody does, what do you call it, the blood does the tamponade for the macular hole. So everything works. But what was the pre-op vision in this case? Because the post-op was 660.
Pre-op also, in this case, pre-op was also 660, and the patient was primary open-angle glaucoma patient. But the vision was dropping down. That's why I have taken the case. The vision was not improved after the surgery, but the hole was closed.
I have one doubt, Atul. When you finally remove the fluid and you have colored the viscoelastic, you also go and remove the viscoelastic that is over the flap?
Yes, yes.
Okay.
Because of the blue color, you can easily see the viscoelastic. And you can take out all the viscoelastic.
Is there a risk of the losing the flap, because the flap can come into your soft tip cannula when you are aspirating that visco?
So we are putting the visco on the temporal side of the flap. Then we are tilting the eye towards the disc. We are taking out this colored viscoelastic from the disc, not from over the flap. So it is ironing out from temporal to the nasal side. And so I'm doing this also, but nowadays, this is a 6-7 years old video. Nowadays, I'm doing the same thing with the help of simple fluid. At the end of the surgery, I'm just tilting the eye towards the disc side, and the water also can do the same thing.
So you are not using the visco with visco, this colored visco now. You are
now from the last 3 cases, I have not used.
Not used. Okay, okay.
Okay, and the only main points are in this surgery is the big flap and drying of the fovea till the end of the surgery. At the end of the surgery,
got
to
it.
prevent retroversion, to prevent the retroversion of the flap.
Thank you, thank you.
Sangeet sir wanted to tell.
Which viscoelastic did you use?
Same HPMC 2%. The same which anti-segment surgeon are using for the cataract surgery.
Okay. I think the Helon GV, if you, the yellow colored Helon GV, you can use and give the same results. Easy to remove also.
But that will increase the cost of the surgery?
Yes, definitely.
And IOP rise is also there, I think, in that case, or Elon GV.
So both will cause the IOP rise if they are left inside the eye.
Yeah, correct.
He's removing it.
Correct. So point well
So
taken.
the Helon GV, it is actually a cohesive, so it comes as a whole. Like when you remove it, it just comes as a whole.
Yes.
So with the HPMC, it's slightly difficult when you remove it. Though this is an idea to color it so that you know where all this is.
Sir, it's not at all. It's not at all difficult because you can take out via passive exchange also. No need of the active exchange. With
No,
the
that
passive
is true,
exchange,
but sometimes you may create pockets. The viscoelastics may spread out and maybe left at one or two sides. I'm just saying that the Helon GV, it stays as a one unit and comes out as a one unit. This
cohesive.
That's why I'm saying this. This coloring this viscoelastic is a nice idea. You know where all these pockets of viscoelastic.
Correct. So thank you again, Dr. Atul. And beautiful technique. Then we come to Divakan Misra. Dr. Divakan, the director and head of retina services, Swarnajyoti Eye Hospital in Lucknow. So he is a surgeon, scientist, leader, and entrepreneur, and a very good friend. Whatnot. Dr. Divakan, very nice video. It's up to you. I'll just play the video. Can I play? Sorry. Sorry. That Divakan, I think you have to just explain this. It's a very nice, but I really apologize. It has not come over here. Management of submacular cysticercosis with coexisting macular hole. Can you play it from your end, Dr. Divakant, or are you traveling?
I'm traveling, so I don't have my system here.
So we'll just try to like to listen from you. Like I have seen the video. The people who has voted, they must have seen the video. So any tips you want to just give in this case?
Right. So it was basically a routine submacular cyst. The another interesting part that we encountered while doing the surgery, probably iatrogenically, a macular hole was also created while the surgery was being performed. Maybe while I injected triamcinolone for my vitrectomy, for my PVD. But we did not do any additional procedures for that because I thought it will close on its own, and the area over the macula was looked very fragile. So doing any other manipulation might have increased the problems for us. So just simple retinotomy was made at the base of this cyst, and it was sucked out and eaten with the help of the cutter, and SF6 gas was injected. The patient did fairly well. He maintained a vision of around 618, and he keeps doing well till now. And yeah, that is it. And anatomically also, we had the closure of the macular hole as well.
Correct. I have seen that. Maybe we will share this in the group also, Dr. Devakant. I think you have the video also. You can share it in the VRSA members group so that all of us, we can see it again.
I'll do that.
Yes. Thank you again. Sorry, I could not play it over here. And may I request again, I think Naresh sir has done in toto removal of a similar case. Your comments on this, please, Naresh sir.
Actually, usually when the cyst is live, it keeps the environment clean. So the vitreous is also very clear, no vitritis. What usually we make is just make a small retinotomy adjacent to the cyst, and with the help of soft tip, you bring it to the sclerostomy port and slightly extend the sclerostomy port, maybe to a 20 gauge or maybe 18 gauge. And usually the cyst will nicely negotiate when we raise the IOP and come out in toto. But many people are just digesting the cyst once they remove it, bring it to the vitreous cavity. But the fun is in bringing it in toto outside. So when the cyst is live, when there is no vitritis, usually that is a very simple surgery to bring the cyst in toto outside.
Thank you, sir. Kim, sir, your thoughts on this submacular cysticercosis management?
I don't know. We used to see quite a few earlier, and we have done quite a few on this. And as Naresh pointed out, it's a very nice procedure to do, because to see the cyst coming out, squeezing by itself without, we never used to eat away this cyst. We let it come in toto. But I think with the current methods, the techniques, eating away the cyst is much easier. But the only thing is you have to remember is to do a complete vitrectomy to ensure you've not left any of the cyst material inside. So that could lead to really a toxic reaction post-operatively. So that's one only thing you have to be very careful about.
Correct, sir. Dr. Divakant, any inflammation or unusually high inflammation you saw in this case post-op?
No, nothing. And we had put the patients on steroid initially, and we continued steroid for a month or so. So no inflammation settled. And while the patient presented also, there was no inflammation in the anterior segment, and very less, there was no vitritis also, as far as I remember.
Topical steroids, you mean to say, right? Not oral?
We put the patient on oral steroids.
Correct. Okay. So thank you again, and nice case, Dr. Divakant. So congratulations, Divakant. Divakant wins 5,000 rupees for this nice case he has managed and documented. First prize winner. Then coming to the month of October, Dr. Manmat is consultant retina surgeon in KIMS, Kalinga Institute of Medical Science, Bhubaneswar, Odisha. And this is the award-winning image, ultra-wide field imaging of Takayasu arthritis. May I request Dr. Manmat sir to please describe this image. Do we have Dr. Manmat sir? Dr. Unni sir, can you please tell about, this is a rare entity, all of us know Takayasu arthritis, but a very large capillary non-perfusion area. In fact, very little amount of vessels are left. So any thoughts on this image, Dr. Unni sir?
No, basically Takayasu is not something that comes regularly to our minds till you see so much pruning in the reaching up to the posterior segment, and that is one feature. There are very few diseases that produce such arterial pruning, of all the vessels and capillary affection also. So the wide field produces a brilliant image over here, which we probably would have picked up using a regular wide field image or a montage image also, but it looks spectacular on the ultra wide field. That's all I can say.
Correct, sir. So, Dr. Darius, sir, any thoughts?
I think it's important that these are patients who are at high risk of neovascularization. So I think now I would proceed with anti-VEGF and laser, and also, be in consult for the primary pathology. But like Dr. Unni said, I think the wide field really gives us a lot of information on the periphery, and we can see how extensive the CNP areas are in this case.
Chittaranjan, if you remember, we had a case of CRO as the launching symptom for Takayasu.
You are published.
Right? Yeah.
You are published. I know.
Yes, yeah. We published, and it was the launching syndrome or the opening symptom for the Takayasu, and it was subsequently diagnosed.
Yes, sir.
After we diagnosed, it was sent to the vascular surgeon.
Yes, sir. So actually, a lot of these kind of interesting images we are coming across, they have a very serious, or at least one important systemic correlation. So there, actually, our role comes, and it's very aptly told that the eye is the window to the body. So that means so many systemic disorders we can diagnose, and rather very serious systemic disorders. So again, this is the description that Manmat has sent for this image, and congratulations. Wins 2,000 rupees as award money for this image, and after this, the power of soundtrack. Dr. Saurabh is consultant VR surgeon in Desai Hospital, West Bengal, and this is the award-winning image. The title is "These are not 360-degree laser marks." So this is the description that Saurabh has provided to us. May I request Dr. Saurabh to please describe the image? Very beautiful image. Dr. Saurabh.
Hello, good evening. So this is a this 13-year-old girl presented in my OPD with 6/12 vision in both her eyes and with night blindness and myopia. So on fundus image, we could see these chorioretinal sharply demarcated lesions extending from the vascular arcade posteriorly to the far periphery, excluding the posterior pole, just like the PRP marks PRP laser marks we find in a PDR patient. So I gave this title because it looks similar to a diabetic PRP. So this is a case of gyrate atrophy, which is a rare autosomal recessive condition characterized by raised plasma ornithine levels due to the deficiency of the enzyme ornithine aminotransferase. Thank you.
Correct. So nicely captured the image, and may I request Dr. Mahesh sir to please tell his thoughts on this disease entity and the imaging per se.
Very nice image, Optos image.
Thank you, sir.
Actually, this gyrate atrophy itself is a very rare thing, and this sort of that round lesions are quite typical in gyrate. I am not sure about the further management on all these things.
Sir,
somebody can contribute.
pyridoxine has shown some effect, but it's not clearly anything right now. 50% has improved with pyridoxine, but not 100%, sir.
ERG, EOG, electrophysiology, what are the findings in these cases?
Sir, I have not done the ERG in this case.
Okay.
Anyone else in the panel wants to add regarding the electrophysiology or other aspects? Okay. Dr. Manoj sir, you want to add anything to the ultra-wide field image of gyrate atrophy?
No, wonderfully captured image actually. Many congratulations.
Thank you, sir.
Nothing more to add.
I have a question for Dr. Saurabh.
Sir.
Why you submitted only one image? Why not the other eye? Any reason?
Both eyes were they both had the same picture, sir, and so I decided to go with the better one, sir. Both had similar type of pictures, sir. Both the eyes.
Okay, so it's a bilateral disease. All of us know. Any
yes.
should not be under the impression that only one eye is affected.
No, bilateral, sir. Bilateral.
I know. I'm just telling. Or maybe the other one, you have got some award somewhere else. It is a copyright issue. That's why you did not send or something. That's what I was asking you.
No, sir.
Okay. So again, congratulations, Dr. Saurabh. So Dr. Saurabh is 3,000 rupees for this nice image. Then again coming to finisher, the first winner of October, Dr. Sisir Varghese. So again, Dr. Sisir gets the second award in this series. I have already introduced him, so no need to reintroduce. This is the very beautiful image, the bullet-ridden retina. So this is the description he has provided us in a case of BR view. This is the image. So there is some novelty, and we must know like how he has captured the image and how kind of it's not a very rare entity, BRVO, and he has done the laser, but how the novelty he has captured, and it is all in the thought process how somebody wants to take the image and get one award-winning image. It will be common entity also. So Dr. Sisir, we want to know about this image from you. That's Sisir.
Thank you, Dr. Chittaranjan. So this was a 56-year-old hypertensive lady who underwent this sectoral laser elsewhere, and then she presented to us with complaints of decrease of vision since 3 months. So the laser was done, and when she presented, her vision was hand movements. And so when I saw that each of those, wherever the laser was given, all that had lifted up because of the traction from that fibrovascular proliferation, and each of those laser scars had actually now turned into multiple small holes. So this is a learning image also, in the fact that you should be careful when you do the laser, especially when you have an extensive fibrovascular proliferation. You should actually stay about 2 to 3 disc diameters away from the prolif, because if traction happens, then all the laser is going to get lifted up, and then it will become turned into a retinal detachment. So that's exactly what happened in this case. And I got this published in the Canadian Journal of Ophthalmology also.
As a cover page or as a clinical image?
As a clinical image.
PubMed indexed article, that
Yes,
means.
yeah, PubMed indexed, yes.
Nice. Thank you. Dr. Unni sir, your thoughts on this, please?
No, I mean, it's a brilliant image and it shows the pathology and the evolution of the pathology. But what this image serves is much more. It actually tells you the how the four-color image creation by the Mirante happens here. So if you look at those holes, you see the orangish color. See, the reflectivity of the different 4 channels are from 4 different layers. And that is why when you see through the holes, you see the color that is portrayed by the RPE, and that is why this image is brilliant. The Mirante has a tendency to produce slightly yellowish images, and a different color bordering a different color for elevated retina. That is why you see the SRF in a different way. But through the SRF, the RPE is being highlighted by the color channels, and that is why the holes are being so highlighted so well. So this is a beautiful way of how a 4-channel CSLO machine works.
Only that there is subretinal hemorrhage also, right?
Yes.
But in that whole area, why it is orange, not subretinal hemorrhage? That's what you are telling.
That is what I'm telling, because the reflectivity is deeper at that point. See, when you take a regular photography, what happens? You will have a shadow over there. It will look dark in color. But when you go for a 4-channel, you can just compare it with the retinal background, the orange retinal background in the area without SRF. The area with SRF affects the reflectivity, and that is why it is grayish over there, much more highlighted. And this is basically an interplay between reflectance and absorbance that we are seeing here.
Fantastic.
Thank you, sir. Thank you for describing the mechanism. Yes, Naresh sir, tell sir.
Similar things can happen in PRP for PDR when the patient has got nephropathy, and if you are giving a very intense one. So we have come across these cases in post-PRP, where when the exudative RD happens, we have got this sieve-like holes in the inferior retina. So that's the reason why we increase the number of sittings in diabetes, as well as the power also should be reduced. It should not be so intense to cause a hole in the retina when the detachment happens, exudative RD happens in nephropathy patients.
Yes, sir.
That's why the old teaching is there, no? Very close to the fibroscular prolif. Don't go very close to with the laser. That is.
So just to add, sir, actually what Naresh sir and Mahesh sir told during our fellowship time, Kim sir is very particular about this. We have to see the urea creatinine, and if it is very high and we have done it in 2 sittings, we'll be definitely scolded. It's we remember that, because you have to be careful. Otherwise, you will end up in again kind of exudative RD, and it may win one award for you, but it is very bad for the patient. So we should not do. So Kim sir, your thoughts on that, please.
You said it. I
Yes,
don't think there's anything to add.
Yes, sir. Yes, sir. Great learning, sir. So, may I request any other panelists to please comment on this particular image or any other image? So congratulations, Dr. Sisi. Dr. Sisi wins 5,000 rupees again as the first prize award money. And congratulations to all the winners. And may I request Dr. Sangeet sir and Dr. Unni sir, Dr. Sangeet sir first, about to tell some words of wisdom to all the participants over here and all the young doctors who are watching this session, and to encourage them for contributing more images and to participate in the competition. Dr. Sangeet sir, please.
Yeah. Thank you, Chitranjan, for wonderfully moderating the session, and congratulations to all the winners of these particular months. And we have been seeing images. It's like simple images winning good awards. And throughout our journey of this VRSI image competition, we have seen images which we would have not even thought of winning. They got the first prizes. And I just want to say that you should keep on posting these images. Everyone who is listening to this program should, that is the message I want to convey. Just keep on posting. You never know when, you never know which image will get an award. So that is that should be my message. And I think that is what VRSI is trying to do by holding this competition. And once again, congratulations to all the images were fantastic.
Thank you, Sangeet sir. May I request Unni sir to please tell some words of wisdom. That Unni sir.
I mean, it was an honor to be a part of this this competition and for this endeavor from VRSI. All I have to say is keep on shooting, keep on imagining, keep on having increasing your knowledge about imaging, and what you see is what you get is what I believe. So yeah, keep the spirit going here. Thank you.
Thank you, sir. Kim sir, please tell few words to all of us.
Thank you, Chitranjan. I think, first of all, I should congratulate you for persistently pushing this and making sure it's happening on a regular basis. I think, as both Sangeet and Unni mentioned, today the entire retina is imaging. The entire work is totally on imaging. And I think everyone should focus on this. And there's a lot of learning. Even there was a lot of learning for me today attending this. Those unique images that you never would probably see. I think it's a real opportunity for everybody. So I think it's a great way of learning. And congratulations to all the winners. And as others mentioned, really I encourage all the youngsters to keep shooting and capturing all these images, because every image speaks a lot of volume, which those days we never had these kind of imaging devices. You have to imagine a lot of things, but today, with the way the images are available, I think this is the way to go. Thank you, Chitranjan.
Thank you, sir. Thank you for emphasizing the need of imaging and the importance of imaging. We have other GC members in this session also, Dr. Manoj, Dr. Piyush. Anyone wants to give their final comments?
Just wanted to add one thing, like we were thinking about how we can compile also all these images and make it as a national image bank for VRSI. These thoughts were there in the previous years as well. So I think all of us should collectively work on this, because these are rare images with a lot of teaching, and even the videos are quite exciting. So we can have it as a separate link on the VRSI website and archive this so that future references, or also the other future generations, will be much more motivated to come forward in imaging modalities. Thank you so very much.
Manoj sir, just to add, all the award-winning images are there in the VRSI website. We can go and visit at any time.
I know that, but I was thinking like we can, has a national image bank, something like that, on a So
Okay, Dr. Manoj, it's a different discussion because we thought of it, we don't hold any copyright because many of these images are published in many journals actually. So they
correct, sir.
hold the no, they hold the copyright, so we cannot have it in our image bank officially. So it becomes a problem. That's the reason why we were saying to encourage the people to submit more. We don't want to hold any copyright over these images.
Okay. Point well taken.
Chittaranjan, many congratulations, first of all. And Mahesh, sir, I'm so sorry that I was not actively involved because we had a simultaneous AIS meeting going on as well. But I agree with what Dr. Manoj suggested, except that it being a topic for another discussion, because it is very much possible that is something that I also wanted to talk about, but perhaps in a GC meeting. But congratulations to all the winners.
Okay, thank you, Dr. Manoj, Dr. Pius. And special thanks to our panelists, Dr. Mahesh sir and Dr. Darius sir and Dr. Mudit. Dr. Mudit probably was caught in some emergency in the OT. So thanks again. And Dr. Naresh sir, any final comments or we'll just close for the day?
We'll close it, Chittaranjan. And I think the people are from all over are there. Maybe they can encourage their fellows to submit the images so that we have more images to come in future.
Yes, sir. So all
We'll send the flyer for the month of January shortly.
Yes, sir.
Because it has been happening regularly for the last 2 years. Maybe we'll continue it.
Yes, sir. Yes, sir.
Thank you very much. Good night, all. Thank you.
Thank you all, and we'll just close the session over here. Thank you again. Good night.
Thank you, everyone. Good night.
Thank you. Thank you.
Thank you.
Thank you.